We all know that we will get weaker and cannot do what we used to be able to do as we get old. The reason for this loss of physical mobility and independence is multifactorial. Much of this is due to the intrinsic factors of disease and the normal age-related changes in our musculoskeletal system. But before we embark on a discussion of the normal age-related changes, I want to remind everyone of the contextual factors which will affect the rate and degree of these changes. Amongst the most important factors are financial resources, nutritional habits, social support, social background, living environment, gender and age, education and intellect, prior life experience. Keeping that in mind, the rest of this video will outline and discuss the normal age-related changes which occur in the muscles, joints, periarticular tissues, and cartilage. A simple graph illustrates that the number of all muscle fibers decreases with age, with the lower extremities more affected than the upper extremities. This is because the loss of fibers is selective, with more atrophy of type 2 fast twitch fibers than slow twitch fibers. In addition, the following cellular changes occur, namely, a decrease in the number of actin and myosin, a proliferation of the SR and T tubule system, a thickening of sarcolemma and collagen in the extracellular space, decreased enzymes for aerobic and anaerobic metabolism, a decrease in the number of mitochondria, and decreased ATP production. The cumulative effect of all these changes is that we lose 20 to 40% of our muscle strength as we age, with a concurrent loss of force development, power, and quickness. There is a specific term for this decrease in muscle mass caused by aging: sarcopenia. A cross-sectional area of an older muscle shows more fat and connective tissue with the loss of muscle fibers. But although mass is proportional to strength and the decrease in muscle mass is indicative of a loss of strength, this alone does not account for all strength loss. There are also changes in the motor unit of each muscle, which contributes to our decrease in strength. Specifically, the motor neurons decrease in number, as do the functional units. This leads to an altered neuromuscular transmission, which in turn results in an increase in recruitment of the number of motor units for any given task. How then is function affected? The decreased muscular strength is noticed by the person during transfers, lifting, carrying, and independent ADLs. As mentioned earlier, the legs are more affected than the arms, with the proximal lower extremities affected more than the distal, and concentric contractions are more affected than eccentric contractions. This all happens gradually, with the individual making subtle changes in body mechanics and movement patterns to accommodate the changes over time. In essence, the person can still function adequately, but he or she does things differently, with less efficiency and requiring more energy. The decreased muscle mass, force development, and power is manifested by movements becoming slower, with a decreased capacity for strong and fast movement. Using walking as a measuring stick, the person will exhibit a slower gait, decreased ankle, hip, and knee motion, loss of sensation, weaker muscles, and poorer posture. Taken together, all these changes can affect balance and increase the risk of falling for all older individuals. This decrease in lean body mass by 20 to 35% between the ages of 30 and 70, coupled with an increase of percent of body fat with aging, leads to a decrease in the basal metabolic rate. The consequence of this is an altered ability to store glycogen, the fuel for the muscles, which then causes a person to have a decrease in their energy reserve. Muscle endurance is thus affected, with a person experiencing increased fatigability and complaints of tiredness, with a need for an extended recovery period after activity or exercise. That is a lot of information to digest, and I hope I have not painted a negative picture. Despite these changes, the good news is that the muscles will still respond well to exercise, and a person can remain fully functional given a proper diet and the discipline to take better care of the aging body. Since muscles don't function alone, we need to also discuss the joints and connective tissue by which the muscles operate. Periarticular connective tissue exhibits some predictable changes, most notable of which are an increased amount of collagen, decreased elastin, decreased water content, and increased cross-linking of collagen. This leads to a decrease in the maximal length at which rupture occurs, placing the patient at more risk for injury. The end result is a loss of range of motion and flexibility with aging. In fact, a 70-year-old person has an average loss of 20 to 30% of the flexibility they had in their youth. What happens to the joints? The hyaline of the articular cartilage is composed of 80% water, along with chondrocytes, collagen, and ground substance. It is porous with the capacity to absorb synovial fluid while being avascular with a poor capacity for healing and repair. Since nutrition occurs via intermittent compression and distraction of joint surfaces, anything that reduces the joint movement compromises the nutrition to the cartilage. As a person ages, there is a decrease in the secretion of the hyaluronic acid, which fosters lubrication, and glycoproteins, which help retain water. As the water content decreases, the collagen becomes stiffer, leading to decreased elasticity and the potential of prolonged compression and disuse. If this occurs, then the cartilage can become weakened and even atrophy. Thus, mechanical degeneration is very common in aging. By age 65, 60% or more individuals report having osteoarthritis. But it is not inevitable and does not de facto lead to degenerative joint disease. Movement is a strong preventive medicine. Let me close with one final note about cartilage. The cartilaginous discs between the spinal vertebral bodies are also subject to the changes discussed. Thus, disc degeneration is common, putting the person at risk for back pain. And as the discs age, they become compressed, resulting in a loss of 1/2 to 1 inch of height for the average older individual.